Hi, everyone. Welcome to our discussion today. Thank you for joining us here on our YouTube channel. My name is Blair Famarin, and I am the president of the local IOCDF chapter here in the Midwest called OCD Midwest. We cover 3 states, Ohio, Illinois, and Indiana. And we use this platform to talk about all things OCD. Today, we have a really important conversation about OCD and culture and how those two interact. I'm here today with Dr. Davis Goodwine and Dr. Cassiday to talk about our super important topic today. So I'm going to send it over to them so they can introduce themselves. Thanks for being here.
Darlene, why don't you go first?
Well, thank you. I am Darlene Davis Goodwine. I am a practicing clinician treating OCD. I'm also a researcher, and I do a lot of work in the area of diversity and cultural training. And so today I will likely just be giving that context. I hope that this feels very conversational and less academic because I think this is an important conversation that should transcend, the stats, the research, although we're building it into research. I want this to be a way for us to land well in our communities and the way that we're thinking about OCD as a lived experience. So yeah, I'll just bat it over to you, Karen.
And I'm Karen Cassiday. I'm a full-time clinician who has dedicated her life to working with OCD and related disorders. And I'm here because I love the fact that there is so much exciting new research and new thought about better ways to help people with OCD and related disorders get better. And I'm dying to pick apart Darlene's brain about culture and OCD. So I can't wait to get started. So, Darlene, I'm going to ask the first question. Um, as a clinician, I've been hearing a lot about diversity and identity and trying to understand that, but I really have not heard much about culture. And I would love to find out first, what do you mean by culture? And how is that different from looking at diversity or identity?
So, Karen, many of you don't know we spent a lot of time last time we met discussing and thinking through like the various ways we learned about culture. And I bring you into the conversation. And Blair, please unmute yourself because I want us to like really have a dialogue. So please jump in at any point around your experiences, because one of the things I realized as I was trained and then have moved into providing services is that the way we learn about culture versus the way I've experienced culture in a clinical space, it seems to be more nuanced. And I intentionally chose the word nuanced and not complex because I think we've kind of internalized this idea that trying to integrate culture into therapy or to anything that we're doing is complex, right? And so when I think about culture, I think about lived experience. I think about lens. I think about, or I think beyond beliefs. I think beyond race. I think beyond religion. I narrow it and bring it back into the lived experience. And I think, how is a person's culture showing up in our space when we do therapy? How does it show up when I greet them? How does it show up when we're talking about or listening to and being invited into others' lives? Like that's what I think about when I think about culture. So today I hope to like pull everyone into that way of thinking. Even as we're talking about it here in this space, just kind of starting with what we have learned about culture and like really anchoring it in the various ways that we can really build upon, especially in the OCD space, how we talk about and even think about adapting and evolving in our clinical space, how we use culture to really inform and understand our even OCD. So that's
Mhm.
what I say to that.
Well, one thing that I was thinking of when you were talking about there is that, my graduate training as a person with a PhD was I was heavily indoctrinated in the culture of science. And then I was taught that that's all that mattered.
Mhm.
as long as I had that way of approaching my patients and a problem and understanding it, then somehow everything would be fine. And I'll be the first person to say, oh my God, after the first year, after I graduated, discovering, okay, no, things don't go the
It's
way they
not
got.
always fit the manual, right?
Yeah, yeah, exactly. I'm like, what? No one, I need a manual for everything else.
Yes, right.
And so one of the things that, that occurs to me is that I think one thing that's really hard for clinicians is learning to think in this broader way. And we might refer to it by saying, "Oh, we're we look at family systems, or we respect, their identities, their LGBTQ plus, whatever." Um, but when you were talking about lived experience, that's something bigger
Mhm,
and something more encompassing. And then as a clinician, I realize I have this tension between, okay, for the sake of insurance, I've got to narrow down a diagnosis.
mhm,
But sometimes that process of doing that doesn't allow for a lot of exploration of some of the things you're talking about or referring to. And I'm curious, what do you recommend people who are working with people with OCD do in terms of the kind of questions they ask themselves about the patient or the things they ask to help them start to think about culture?
So Blair, you're nodding. I don't want to leave Blair out before I ask or answer. So Blair, I see you nodding. Is there a particular context or a particular experience you would add to that just to bring it to life?
I just like how you say lived experience too, because I know we were talking previously, and when I think culture, I don't think me.
Mm,
Like I don't think like a cisgender white woman, and last time we talked, you were like, Blair, you have culture. What are you
yeah.
talking about? So I
Sorry, you
love
see my
how
face? I was like,
yeah,
really?
you include everybody in that, and everybody has a culture, no matter their background and where they came from. That was what makes their culture. So I like that you really don't define it as like diversity, equity, inclusion. Culture is a lot of things.
Yeah. Yeah, so you added something else. And if you see me look down, it's because I have to write things down so I don't forget my points. So going back to your question, Karen, and even hearing Blair say that, you asked essentially, if I had to summarize what you were trying to get at, like what, how would I direct a clinician around this dynamic?
Yeah,
Is that what
yeah,
I don't want to oversimplify it, but
exactly.
that's what I took from it.
Yeah,
Like, how do
yeah.
I guide a clinician? And then I'm so glad I kind of batted it over to Blair because, her lived experience as a clinician, I imagine, right, is saying like, dang, sometimes when I learned about culture, I didn't even consider myself. And I
Well,
think
I would
honestly,
agree with Blair is that
oh,
I was always taught culture was about people in other countries that are extremely different.
yes.
And, this is okay, white superiority syndrome, but I'm the neutral,
Yeah,
there's nothing interesting or different. Just
about
assume
me. Yep.
it's kind of like whatever I have. Um, and I realize even now, as you said that, Blair, I'm like, at first I go like, what is my culture? I'm like, not sure what to say. Uh,
Yeah.
and
Yeah. And I think that goes to the question and to the experience as the clinician. And at some point I'm going to shift to the individual with the lived experience because I think there is a lot of interaction that happens, right? So if you have a clinician, because the common demographic of an OCD clinician is a white woman or a white
Mhm.
male. And so I think that's uniquely anchored in this space because if the majority of the American, because we do have to keep in mind we are an international organization,
Mhm.
if the majority of the American clinicians hold or host that dynamic or are working through to come out into their fuller culture, then that's honestly what an individual with OCD runs up against, right? So that is what's happening. So the ability to host a space where you're able to facilitate um, exploring culture as a facet of OCD symptom presentation is really interesting, because you're kind of going through your own experience, right? Like, so you're trying to do something while also trying to hold and facilitate that experience for someone else. So that can be really challenging. Now, what does that look like, right? Because we know that the background on OCD treatment, like, it works for some, it doesn't work for others. We know the stats. So it's not that there is this necessary harm in the way that we think about it. Here is what I propose is happening, though. In the way that OCD shifts and taps onto the identity, what is likely happening in those spaces is that clinicians are not seeing or are not catching that particular cultural facet of OCD shifting in the treatment. So there's essentially a cultural blind spot, if we have to give it a word.
Yeah.
And so the interesting thing about that, to answer your question, Karen, like, what would a clinician do? What I've proposed, and I actually will be talking about this at the Advanced Forum that's happening in Toronto, Canada. Isn't it in Canada?
Mhm.
I know it's
Yeah.
in Canada.
Yeah.
It's
In
in Canada
Ontario.
in October.
Yeah.
I'll be talking about this concept of conceptualizing culture, right? And what that means is, one of the things where OCD clinicians are uniquely positioned is that, just as you said, Karen, we are all taught the science of treating OCD, as we should. Let me be 1,000,000% clear. It is super imperative that if you are a provider working with OCD, you must know the gold standard. Like, you have to know the science, you have to know the framework, you have to know the manual, like, you have to know these things. And in that same breath, to your point, Karen, once you got out there, you realize, like, wait a minute, I need a menu for everything. There's no way I'm going to be able to treat all this. I need a menu for all the things that are coming. And here's what I say to that. I say we don't. As OCD clinicians, we are uniquely positioned to know how to hold space for something that is ever changing. And the framework in which we do that is we learn the foundation, we learn the system, we learn the science, we learn the framework of how to effectively assess and then set up a treatment process and then move a client through the treatment process, even as OCD is shifting and moving. And what I propose and what I've been proposing is that is the exact same way we could think about culture. We do not learn everything there is to know about OCD, because we cannot. We don't know everything. We put dimensions up there, we get a sense of how it shifts, and then we move through being very effective and intentional about our assessment process and our updating of our conceptualization and our constant checking in. And so that is what I propose we do with culture. You are not tasked with finding out and learning the culture of every single person that comes into your clinic, right? We get the same foundational training in the diversity class or the multicultural class. And to me, it is very limited, but we get it. We get a snapshot of everybody's culture, just so that we understand that, there are very specific facets that might show up generally in many cultures. And so that's honestly what you need, because if you approach culture the way you do OCD, you're constantly keeping your eyes and ears open for something that might change. So what would I tell a clinician? One, I first would tell them to anchor themselves in their own cultural identity, because we all have one. So do that work. That work is imperative. If you haven't tapped into whatever your culture is made up of identities. We all have identities. Blair's cisgender. I am a cisgender Black female, right? Like, that is me, who's raised Southern Baptist Christian, but doesn't practice per se, right? But I have a belief in God, right? I have an understanding of Jesus. And I'm also a historically Black college and university graduate. That in itself is a different kind of Black, right? So it's these ideas of, as you grow to learn about your client and you start to hear the different cultural facets that show up, people will tell you that. They tell you that. And as we move through the DEI realm and we start talking about how to assess culture, and you start capturing the little snapshots in the beginning, as you start moving through, you start listening for how it's showing up. So you're not tasked with knowing everything there is to know about all the things. But I think that's the myth. That's what we've been taught as how we approach culture. We must know all the things about the things. So I can stop talking now. Any thoughts?
I think it's interesting what you're saying kind of makes me think about how sometimes we have to dig for the compulsions too. When people come in and they say, I only have obsessions, I have no compulsions. Maybe that's true, but oftentimes if you dig deep enough, you can find a mental compulsion or some other thing that they're doing that they don't realize is the compulsion. And maybe you can dig deeper and find out what the culture is too. And maybe some things are fusing onto the culture because we
Yeah.
know OCD attacks what means the most to us a
Right.
lot of the time. So that's probably part of their culture.
Yep. And
Yeah.
sorry, were you gonna say something, Karen?
Yeah, I was going to say, it's interesting because I think I learned, you know, about OCD first in the, 80s.
Mm.
And then went into practice in 1990 for the first time. And we were taught over and over, the content is irrelevant. The content is irrelevant. It's just the function. That's all you're looking for. And then, of course, there's been a very interesting shift in how we think about OCD and realizing actually the content is significant. And
Yeah.
especially, some of the newer approaches we're using here, the inference-based cognitive therapy,
Yeah.
that has a very strong cultural element
Yeah.
to it.
Yep.
In fact, it's all about that,
Yeah.
about how someone learned to make conclusions
Yep.
and interpret things. And, and it seems like we keep, learning more and more about how you think is critically important in terms of treating OCD. It's just not a matter of can we get you to learn how to be scared and tolerate it without avoiding it?
Yep.
Um, which is, I think, my understanding of exposure therapy when I first graduated,
Yeah.
as opposed to we're trying to help someone understand their worldview
Yes.
and what aspects are serving them well and which ones are not, and then trying to help them create a well view of themselves and their world and their relationships and live into that. Um, and that's a you know a much more nuanced process than I think I was initially, led to
Trained
believe. but,
yeah, trained
but
to
I,
think
but I also
about.
realize, when you start out understanding any disorder, you have to start at a very basic level and work down. And thank God we're at a time in history where we have lots of options for people
Yeah.
with OCD, not just one treatment or one medication, uh, that way. I'm, curious if you could share some examples where you realized either for yourself or when you were mentoring someone or supervising someone where you realized there was a mismatch in understanding about cultural issues and working with someone with OCD.
So I'll give you an example of something that I thought would have gone under my radar had I
Mhm.
not held this conceptualization.
Yeah,
Like,
yeah, that'd be interesting.
um, so and a therapeutic experience that I had, and for the sake of just like keeping too much detail out of this space, a therapeutic experience that I had where I really had to expand my own idea about culture is it never dawned on me that OCD would take something as simple as a developmental educational space and like just hijack it. And what I mean by that is there are often times where our clients are experiencing just basic developmental shifts in their lived experience. And that's why I keep saying lived experience, because imagine a middle schooler, right? And this is not the case, but imagine a middle schooler moving into middle school, and you know what comes with that, right? Like now all the peers are looking at me, and now that matters. And here I am having traditional everyday concerns about what my peer age traditional concerns that OCD just hijacks, right? And so it doesn't sound like the typical dimensions, right? I'm not concerned about washing. I'm not concerned about those identities. I'm literally moving through a teenage identity, and OCD is hijacking it and has me obsessing about not whether they like me, not whether all the
Yeah.
it sounds like, let me try to frame it to where it does not give too much input, but it really just like hijacks this idea that you should question everything about your experience and literally cycle into obsessing it and the implications behind that. And that now, does that make me a bad person? Or, and not that I'm embarrassed or concerned, but like, what does it say about me now that I'm thinking these things, even though it is a traditional adolescent mindset, right?
Mhm.
It's that kind of thing does not fall into a category that we would think like, oh, this is cookie cutter OCD. And I've had this experience several times where it's like, because I have a background in child development, I understand developmental phases. So I know typicality across developmental
Yeah.
stages. And so it's unique for me when it comes across and I'm able to help a person say, hey, no, that is like your OC, like really kicking your butt, when they're like all tapped into typical adolescent angst and distress.
Mhm.
And one could say, oh, this is just anxiety, or they're depressed, because that's what we put on young
Oh,
people. It's
yeah.
that kind of thing, where that is what I mean by culture.
Yeah.
Someone would not see that as culture when that is what I mean by culture, because
Mhm.
it's developmentally anchored, it's anchored in this here United States, and how youth navigate through educational spaces. It's a whole culture. Being a middle schooler is a whole culture. Being a college student is an entire culture, right? So we think
Yeah.
about those things, and it's important for us to have that kind of mindset, so we're not always just looking for race, we're not always just looking for gender, we're
Mhm.
not always just looking for sexual orientation, right? Like, we have to understand and be able to host a space where we're really getting people to look at their identities, that our identities are not just factor into social norms or what people impose on us. It is through our lived experience. And that will be a cultural example of how it's important to really think through. That's not something that I would obsess for. What, are
Yeah.
you having these particular concerns as a middle schooler? No, I'm not assessing for that. I would have completely missed that, right?
Yeah.
But that's what I mean about being open and like moving with the client to like, oh, OC has really like grabbed into this particular identity aspect of where they are in life. So that's an example.
That's interesting because you're just making me think about someone I saw recently who's about to become a parent,
Mm,
and they had seen other therapists and were understood to be someone who was having normal concerns, because they're losing sleep about, the baby's going to be born very soon, and how am I going to manage this with my job? How am I going to, handle all this? Uh, and I think one reason it was seen that way was here on the North Shore of Chicago, where I work. Um, a good parent, according to the North Shore culture, is someone who goes to great effort, is
yeah,
constantly worrying about their kid, their role, constantly examining their conscience and putting forth a lot of effort.
yeah,
However, when I saw him, I'm listening to this and I'm realizing he is obsessing.
yeah,
This is way beyond normal concern. And people had been kind of giving him kudos almost,
yeah,
because isn't this great? Here's this
mm,
person who's showing, and they were male gender. And
yeah,
I think it was seen as, this is extra good that,
yes,
the dad is so concerned about this, where he's losing sleep, he's stiff and sore from worry, he's getting constant intrusive thoughts of bad
mhm,
things happening at work, with his marriage, with everything. And then there's no real, evidence that supports that. And, and to realize that this is OCD, and I like that term, it's hijacked this
yes,
situation, and no one's thought to treat it. Uh, and then in talking with him, he hadn't thought of it that way. He just knew he's miserable and something's wrong, and I would like to not feel this way
yeah,
about what's coming up in my life, and that I can tell that the net result of this is bad for me. And I'm
Yeah.
annoying my partner and everybody else as I am, getting in tears about it. Uh, and it's a great example where I think people weren't asking themselves those bigger questions,
Yeah.
and it appeared to be normal, so to speak.
Yeah. Yeah. And I think that's an interesting thing too. It's like this idea of I forgot where I was looking at this, where one of the cultural factors that comes forward is really exploring messaging about from family culture, right, or expectation, like how one goes about um, correcting or getting help, or what their thoughts are about how to address things like that, right? Because imagine coming from a family where your culture tells you, oh, man up, right? That's a culture.
Mhm.
Culture tells you, man up.
Yeah.
You're about to have a child, you're
Yeah.
overreacting, get it together, pull your pants up, figure it
Yeah.
out, keep going, you got to take care of a kid, right? Imagine if that was the messaging, right?
Yeah.
um and that's the context, and that's an example of conceptualizing culture, because
Hmm.
at that point you're going to look for where OCD is going to attack there, right?
Yeah.
It's going to attack who you are in how you see yourself, right? So that leaves you open for the depressed mind, right? Because you're
Yeah.
failing. And then you have OC picking up like something that's important to you, got you catastrophizing thinking, right? So like look at that. Look at that. Again, we've yet to talk about any of the other stuff that we normally talk about, right?
Yeah.
This is why it's important for us to really rethink how we are learning culture, because we're missing opportunities to really give people language and give people context to their
Mhm.
distress, all because we're thinking about culture in the ways that we do. Now, does that eliminate our responsibility to gain a better understanding and a deeper understanding of when culture is like obvious, right? I'm a Black woman, so clearly I'm going to have a more obvious culture. Yeah, no, it doesn't alleviate that, but that might be not be what I care most about in that moment. Like that might not be where my OC is at the moment, right? I might not come in with my OC there, but down the road, something Kamala Harris comes on TV, and then
Mhm.
there's all this information about Blackness, and then oh my God, does that mean I'm Black enough, right? Like OC just picks it up, right?
Yeah. Yeah.
These are the examples that I'm saying. Like I came in for something related to having a baby, right? Or postpartum OC, right? And then now it's done attached to my Blackness. This
Mhm.
is what I mean. I need us to have an awareness of our clients, possible cultural spaces, and the way that we have awareness of the all the dimensions and the ways that OC can shift. I need us to be tracking culture in that way too, not from a space of I need to know all there is, but I need to have checked to see what identities are present with me early on, so
Mhm.
that I can track. So I'm not, because otherwise they lay hidden. OC will
Yeah.
hide in a really cool identity that we never thought about.
Mhm.
So
Yeah. Yeah.
I've
One thing
seen
I hear
this.
you. Oh, go ahead,
Oh,
Blair. Yeah.
sorry. I was just gonna say I've seen this with what we normally think of culture as well, like a religion.
mhm,
I know on the North Shore, there's a lot of clients of Jewish background, and a lot of times people were being seen as like the best,
yeah,
the like best prayer, the best person to make sure everything was clean when they can't have their milk and their, I mean, I'm not the biggest Jewish expert, but like milk and meat. And it was like they were so good at it, but then deep down, it was a lot of OCD coming up and it
yeah,
was attaching to that because that was what was very important to them.
yeah.
So even in just very obvious cultures like religion, I still think we need to dig in and make sure, like
Mm,
what Dr. Cassiday was saying with her guy who was going to be the best dad, is
yeah,
that really what's going on, or is there something else underlying it causing these people to be miserable?
Yeah.
yeah. And
No,
it
well,
goes in opposite directions, right? Like,
yeah.
am I being the best, so I'm going to work more, or am I avoiding something, right? Because like the sacrifice. So like Black Christianity is like the sacrifice. Jesus great gave his life. So are you sacrificing enough? Are
Yeah.
you right? Like so looking for both extremes, right?
Mhm.
Like are you avoiding or giving of, or harboring, or that kind of that sense, or Am I fully engaged? Am I behaving and practicing? Both of them are extremes. And I think in religion, specifically, like you're looking for those extremes. And even for the sake of culture, right? So you gave the dad example. So there's a good dad, and then there's like, okay, like that's a bit much. Right? Like, and not the overbearing, overprotective dad, but
Yeah.
like the OC dad is gonna look completely different than an overbearing dad, right? In here.
Mhm.
So I think you make an excellent point, like looking for that nuance, that level of comparison, tracking that.
Yeah, well, it's making me, think of this idea of, when we talk about implicit bias, where culture can get us caught up in that without, understanding it. And I certainly, I see this happening, um, both with therapists and with patients, with myself, with others. And I think it's, what's I think difficult for all of us is you mentioned the idea that I have to define where I'm coming from, um, and understand how that comes out,
Yeah.
uh, and how it affects how I assess people or understand them, and then also try to understand that patient's perspective. Uh, because I mean, one thing I that I see, and I was just thinking like this idea, if you work with kids and you're in
Yeah.
the anxiety realm, everybody's always talking about, overprotective parenting, helicopter, snowplow parents, whatever the extreme word is. And there's many variants of that. And it's not a one size fits all thing. And I was just thinking about this where I live in Wisconsin, but I work in the Chicago area. And the minute you cross the state line, big culture change.
Mm,
And you'd be surprised. And so, one thing that's very valued in Wisconsin, is being, very, I guess the best way to put it is being very cooperative
mm,
and not making waves. It's very part of the, kind of keep your mouth quiet if you
mm,
don't have something nice to say. And if you kind of want to think, a lot of German Lutherans and
mm,
some of the culture there and not complaining a lot. And then here
mm,
where I work on the North Shore, um, there's a very different approach. And I remember when I, started working here, I was raised in I'm going to call it the white Anglo-Saxon Protestant realm, which was, um, if you don't have something nice to say, don't ever say it. Don't fight, don't argue,
mm,
keep it to yourself if it's negative, and be very, very polite. And it's better to understate things than to overstate. And I stepped into this situation where people would just come out, and I experienced all my clients as being, oh my God, is there anything they won't say or won't talk about?
mm, mm,
Where's their filter? And,
mhm,
um, and I had to learn to change how I talk because I realized I'm understating things and not
mm,
making my point. I have to be very clear. And I realized also I was tending to overinterpret. So, in terms of what a fight meant, because in my culture where I grew up, I never ever saw my parents fight. I didn't see any other parents fight. All the churches we went to, that would have been a shameful thing. It was better to
mm,
just suck it up and shut up. And here it's seen as you don't love me if you're not willing to fight with me.
mm.
You express your
Wow.
love by showing your emotion. And, and then also there was this sense of, and I had some clients, Jewish clients explain, said, when you've been persecuted for millennia,
Mm,
and if you've lived in Israel, you realize life happens now and it's too short to not talk about what matters right now. You live intensely because you could be gone tomorrow.
mm,
And I had never, ever thought about that. And I had to learn, wait, this is expressing something important. And I need to not look at it as like, holy cow, um, you guys don't know how to handle conflict, as opposed to this is a different way to handle conflict. And actually, a lot of the times it works well. And I can also say from my upbringing, there are a lot of times that didn't work well. Uh, you know, in terms of my sisters and I all talk about, we all had to learn how to be assertive.
Yeah.
Because that just wasn't something you did.
Yeah.
Uh, but it but I see where it made life difficult for me and my patients at the start because I'm just reeling inside from just the way that you're supposed to express yourself or not express yourself. And,
Wow.
and now I can say, after many years, like, I feel very comfortable uh,
Mm.
in this setting and I understand it differently. But my initial understanding was, I would have been right away going like, whoa, is this family ever dysfunctional?
Yeah.
Um, coming from my culture as opposed to understanding, actually, they're functioning quite well. Uh, people aren't having huge problems from this. Um, I'm the one having the problem.
Yeah. So first off, thank you for sharing that. That was all new to me. I love learning stuff, and I have never known that about what you call it, German Lutheran? Is that what you call
Yeah,
it?
yeah, yeah. If you,
So I
uh,
know the Protestant thing, right? Yeah, I know all that.
yeah, yeah. No, it's you're stoic. Uh,
I-
you're there to work for other people and serve people, and there's things about it I love, but it's seen as unseemly
Interesting.
to complain.
You have opened my eyes. I would have never.
Yeah.
I've never like. Interestingly enough, that's never taught. And so this is the limitation to
Hmm.
why it is a problem that whiteness has not been defined as a culture. Because if I know I've had older white female clients, like I would have conceptualized that completely different. I would not have put that in the context of family. I would have
Hmm.
put that in the context of something happening. And so there's some withdrawing or some challenges and commute. Like I would have never. So thank
Hmm.
you for sharing that. This is the importance. This is the importance of conversations like this because it provides context. Um, man, you just taught me something. My brain is spinning because I am so excited. No, I'm serious. Oh my
Hmm.
goodness. Um, because it also brought up something that I know we're getting close to time, but I wanted to anchor this idea into this space, and of course, it's something that we can build upon. But pulling it all back in together as to why now, to your point, Karen, we were thinking about like how values have been infused into how we do OCD treatment, and I think this is why, right? Because it allows us to get a sense of how folks are making sense of when OCD attacks their identity, like what they're doing with it. And so we're able to anchor them around what is true, right? What they were raised with, what are their values, what's important to them, even when OCD likes to grab at it and take it. And as you were sharing about your experience from a clinician standpoint, I think that's a important piece of this too, right? Like anchoring ourselves in what's important to us and even using that to kind of anchor our understanding of our clients, right? Because um when we start to say what's important to you, it really allows us to be very attuned to where OCD might attack next. So it allows us to be like really strategic. Um and that again expands our understanding and ideas about culture. What's important to you, but also what did your parents tell you was important to you versus what you walked away actually living out, right? Like that
Yeah.
gets way more nuanced. Very interesting.
Yeah, I
Very
liked what, Blair, what you were saying about how OCD always wants to attack the things that are sacred or that we hold sacred or that our culture holds sacred. And it and it's so frustrating for people who have it um, because of that, because it hits where it hurts.
Is there like from you all's perspective, is there one thing that you feel like we should say to the folks who have this lived experience that might validate or inform how we plan to continue these conversations and moving forward around culture and speaking to their experiences? What would you say?
Well, I think, what occurs to me, because I'm trying to think practical from the point of view of a patient or clinician, is to be willing to take the time to learn what's really important to you. And I like that, what was really important to the people who raised you.
Yeah.
Because of course we're always reacting to that, whether we agree with it or don't agree with it. We can't help that. And then, eh, that would be one thing. And as a patient, be willing to express that.
Mm.
Because of course, depending on who you go to see, they might have time constraints and they're just trying to figure out the diagnosis, what medicine, or get you started in treatment. And um, it's important for you to bring it up. And I'm thinking in a way that's beyond, like a acceptance and commitment therapy, values assessment, because those have to do more like with character qualities.
Yeah.
Um, in this broader way, because as I've been listening to this, I'm realizing those are the questions I need to ask, are the ones that, um, as I get to know someone, that starts becoming very meaningful.
Mhm.
And realizing, okay, this is why this particular thing is so painful or difficult, because of what it's attacking and the context it fits in. And I a lot of times need explanation for that,
Yeah.
because I wasn't raised that way or in that setting, and or I may not have had a lot of patience with that particular background.
Yeah.
I agree, and I think that just taking the time to explore those values and culture is what's important too, and as well as understanding that not everybody has your same culture. I mean, just because Dr. Cassidy and I are white women doesn't mean she grew up anywhere near what I grew up, and same with everybody else. And sometimes you might have to explain to your therapist what your lived experience is and what your culture is, because we might not even know the right questions to ask. Like Dr. Goodwine, you wouldn't have even known to ask about German Lutheran because you didn't even know it was a thing. So I would never know how to ask about like an HBCU because I never experienced that. So I have no clue. So like, you might have to give me more information without me asking, or help lead me to ask some of these questions because I don't know what I don't know.
Yeah. Yeah.
Yeah,
That's valid.
right,
That's very valid.
right. And I have to say, I have always been so grateful when I've had patients who point out to me, no, no, you didn't get it right, Karen.
Ooh.
And I can think of one in particular who, very early on in her treatment, realized I wasn't understanding her perspective. And she, stopped me and said, no, you are not understanding. And of course, it's a little embarrassing, but also I'm like, well, help me, please
Yeah.
tell me
Yeah.
what I understand. And it changed everything
Yes.
in terms of the treatment. And at a certain point, it also made me realize I need to refer you out now to someone
Yeah.
after we met certain markers, because you need someone that is more experienced in certain aspects of your culture, because it's getting in the way of treatment.
Yeah.
And I wouldn't have known to do that. I would have misperceived it as, poor communication, as opposed to some of her experiences were so radical and so different. They were, quite frankly, very, very hard for me to understand and figure out how to help her in that.
Yeah. And I hear in sitting in this space, I hear two sides of that I think we are tasked with in this space. We are tasked with supporting clinicians and having that awareness to say, hey, I I've given the support that I basically scope of practice conversation, right? Like at this point, this is outside the scope of my practice because this cultural nuance is so above my knowledge and capacity that I am going to support you in transitioning so I can ensure that you get the help that you need. we encourage that, but we also support clinicians in getting that language and knowing how to do that, because clinicians are human and we have egos, and sometimes in our response to try to protect that, we might lean more into the resistance conversation, or this client is just not really an effective communicator, so it's following them. I think it is a relationship, and I also think it's helpful to lean on the side of the client to say, this is not a rejection of you. If we have to transition you forward to someone else, it is a transition forward. It is not a referral out. This is not a punishment. This is recognizing that we've worked as far as we can go, and the nuance of your presentation is, again, you are better supported somewhere else. Now, on a global level, we, though, as a community, have to start being able to track where these pockets are, because here's what happens. I take you as far as I can go, but there's nobody I can send you to.
Yeah.
So now I'm spending the next 4 weeks trying to find a clinician. Am I lying? Am I lying? I'm spending the next 4 weeks,
Yes.
and this client's treatment is stagnant because we as clinicians are in this space, we don't have like little bubbles or pockets for the specificity of culture, because we're just now opening the dialogue around conceptualizing culture in a way that we need to. So I think that's our responsibility, and our next step for our OCD community is to empower the clients to speak about their truth and their experience, so that it is tracked and anchored in what's important in their identities and their family experiences. And then we're on the other side, which I know IOCDF has the website where you can like look by race. I think they have that, or by culture. I think it's like race and ethnicity or something like that. But I think professionally, I think we should start building these pockets, right? So that it's not just one, right? Like I'm one of how many? Like I am one of how many Black clinicians who treat OCD, right? Like we have to find networks. And I know that we, again, are uniquely positioned because we have licensed clinical social workers who want to treat OCD and licensed practicing counselors who want to treat OCD, right? So I think we have a call to action to do that part as well, so that we can support the clinicians who are in the field, to give them like, hey, shoot them over there, right? You can do teletherapy with them over there, or like, hey, you consult with this practitioner. They don't even have to leave you. Just let's start a consultation relationship. You can keep them. You already have a rapport with them. If you want to circle me in and we can have a conversation so that they kind of know they're safe and who the information is coming from. Like there are all kind of ways we can get creative about this. I just don't know that we've approached it that way yet. And I feel like we're onto something in this space. So maybe that's further in the conversation, empowering the clients and understanding we're intentional about doing this work.
Well, that is fascinating, because you made me think, okay, the one group at least in the United States, where we openly go after cultures for veterans, that we understand they share a unique and powerful experience. And we don't do that for anybody else.
Right.
And then also I was thinking, every time I go to like a networking lunch of other clinicians, we're trying to, in effect, sort of market ourselves and find where can we refer people.
Yeah.
We always introduce ourselves and saying, I work with this kind of patient, this kind, and no one says, something like, hey, hi, I'm Karen. Besides working anxiety, I'm the mother of, a son with disabilities, and I have a stepdaughter with severe disabilities that lives in a group home. And I'm an Air Force brat. And those things are kind of unique. And I sort of get those populations better than most people. It's easy for me. You never say that.
Yes.
But I'm thinking, when I've made some of those specialized referrals, I'm like, oh, here's Jane. She suffered with infertility and she adopted some children, and this client's really struggling and they need someone who gets that. Or this person gets chronic pain and addresses in a way no one else does because they've lived it. And I'm not saying you have to necessarily have lived it, but you appreciate something and can be more efficient as a clinician sometimes if you really grasp the culture. But you're making me now, I think I'm going to pledge to try and introduce some of those things about myself rather than the boring, hi, I do evidence-based treatment for anxiety disorders, and I love working with difficult patients. Please, here I am.
I never said that, but I'm like you. Like the spectrum, right? I want the ones all over here. Like give me the most severe cases. Like I want the hard stuff.
Yeah,
They're like,
yeah,
listen, I need to train. There's this clinician. She loves this stuff. Here, let me send you right on over to her.
yeah.
Yes,
Yeah,
we do. We do.
that's a very interesting idea because we're now introducing ourselves, at least by these are my pronouns.
Yeah.
Blair started off, I'm cisgender, but yeah, we got to go a little beyond that and maybe be a little more vulnerable.
For the clinical space, for networking,
Yes.
because obviously we're
Yeah.
not going to go out everywhere, but I think as we're thinking about how to facilitate what works, because this is what works,
Mhm.
y'all. This is how we can increase and improve outcomes.
Yeah.
We pair, right? We started out the old research, let's pair by race, let's pair by gender. And then we realized there's more nuance than that, right? So here's where we can start that practice. And it doesn't
Yeah.
mean we have to add a segment like pronouns or anything like that. But like as we are networking, let's start thinking about, especially in OCD, let's start thinking about like, hey, what's your gig? Right. And that might be, look, my gig is this. My gig is substance use and suicidality. That's my gig in OCD and in college students. Oh,
Mhm.
that's my gig. Yeah, I really do. Oh man, they are so fun. They are so much fun. That's my gig. So,
Yes.
yeah.
Yeah.
We are coming close to the end. I hate to end our conversation because it's been so great and I've really enjoyed hearing from you both, but in the, just because of time, I think we should end soon. Is there any last minute words of advice anybody wants to leave?
I think this is such an interesting topic because until I met Darlene, several months ago, I hadn't even thought about this. And I assumed culture was that thing you learned in social studies about people who were really different, living in different parts of the world.
Yeah.
And I honestly hadn't thought about it any more than that. So thank you, Darlene, for expanding my mind and hopefully my clinical practice.
Yeah.
And then you're also just making me reflect on things that I hadn't appreciated this way. And it makes me want to be more thoughtful.
Yeah.
Uh, and then also, I love the idea of the way you let other clinicians know about who you are
Yeah.
beyond your, I'm going to call it your technical expertise.
Yeah. Yeah. And I think that's it. So thank you. First off, thank you, Karen. And thank you, Blair and Mike, for this opportunity to have this conversation. It's something that I discuss often because I'm super passionate about it, not because of the DEI space. We didn't even get into the DEI space. For me, it's sometimes intentional because I don't want the term culture and what we're talking about to get lost over there in that kind of categorical way that we go about it. I want it to stay over in the experiential, thoughtful. If I had to leave and plant one word, it's that. Like, I want people to just be thoughtful about culture. You don't have to learn all the things. We all get the same training. But when you get a client in there and it appears that, and this is not an assumption or stereotype, no, it is important that we anchor ourselves in the culture of our clients. And hopefully, what folks have heard is that culture exists in whiteness too. So start with those folks as well, right? The obvious ones are the brown and the black folks and the LGBTIQ community and like the religious folks, but no, like a general, regular white woman, white man has cultural aspects as well. So be looking for those because culture is a lived experience. It's not just a term or a checklist of holidays and things like that. So feel empowered, individuals, clients, feel empowered to bring that forward into your clinical space so that it puts us as clinicians in a space to continue to evolve around our ways that we're thinking about this and supporting you. That would be my closing statement.
Thank you both so much. I can't wait to put this up on YouTube and have everybody watch it. And hopefully we'll continue the conversation again in the near future.
Yes, looking forward.
Thank
Thank you all.
you.
Thank you,
Take
everyone.
care.
Bye-bye.
Bye.